So, good evening. Today's topic of discussion will be on entropion and ectropion. These are the past year questions that have been asked on this topic. We'll be first going through the relevant anatomy, clinical evaluation, and the theory on entropion and ectropion. So, coming to the relevant anatomy, the lid margin, it is a flat platform that lies approximately at right angles to both the anterior and posterior edge of the eyelid. It classically is described to have two lamellae, anterior and posterior. Anterior lamella comprises of the skin and eyelashes, orbicularis oculi muscle, and the associated glands of Zeiss and Moll, while the posterior lamella has the tarsal plate, conjunctiva, and the meibomian glands. It is divided by a gray line, which is nothing but the terminal extension of the orbicularis muscle. It's also called the Rheolian's muscle. Also, there is a middle lamella that has been described, which mainly is the orbital septum along with the pre and post septal fat. Also, in the lower lid, there is the levator palpebrae superioris muscle, and in the upper lid, there is a levator palpebrae superioris muscle, and in the lower lid, we have the capsulopalpebral fascia. Next, we move on to the vertical lid supports. We have the protractors, retractors, and some ligaments. Protractors are just the orbicularis oculi. Retractors are different in the lower and upper lids, as we will see. And the supports are two ligaments, one in the upper and one in the lower lid. So, coming to the protractors, orbicularis oculi is a muscle that is arranged in several concentric bands. It is divided into an orbital and palpebral portion. The palpebral is further divided into pretarsal and preseptal. So, the orbital part is mainly for firm closure of the eyelids, while the palpebral part governs the gentle closure of the eyelids. Next, coming to the retractors. The retractors of the lower lid primarily is the capsulopalpebral fascia. It takes origin from the fascia surrounding the inferior oblique and the inferior rectus muscles, and it inserts into the inferior tarsus. So here you can see that this green portion is the capsulopalpebral fascia, and this is the inferior oblique and the inferior rectus muscle. Moving on to the other lid supports. So superiorly, we saw that there is the levator palpebrae superioris. It originates from the lesser wing of sphenoid and inserts into the superior tarsus. So next, coming to the Wittnall's ligament, it is the superior transverse ligament, and so basically the function or the important thing about it is that the LPS muscle, it is the point where the anteroposterior direction of the LPS muscle then becomes from superior to inferior. It is analogous to the Lockwood's ligament inferiorly. This Lockwood's ligament, it forms a hammock-like support below the globe. It is formed by the fusion of the capsulopalpebral fascia along with the facial sheath of inferior oblique, and it extends from the lateral orbital tubercle to the medial canthal tendon. Coming to the horizontal lid supports, we have the medial canthal tendon first. So as you can see, the orbicularis oculi muscle, the palpebral portion of it, it's forming the medial canthal tendon, which in turn then gives rise to three limbs or three reflections. There is the anterior, posterior, and superior. So it's better shown here. This is the medial canthal tendon, and here you can see the anterior, the posterior, and the superior reflection. Okay, so then moving to the lateral canthal tendon, it extends from the Wittnall's tubercle and it inserts into both the tarsal plates. It has the upper and lower limbs. The third one is the tarsal plate. It, again, the superior and inferior one. The superior tarsal plate tends to be thicker as compared to the inferior tarsal plate. It gives that skeletal framework to the eyelids. Moving on to the normal eyelid, this is the position of the normal eyelid. As you can see, the upper lid covers the superior 1 to 2 millimeters of the cornea, while the inferior lid rests at the inferior limbus. The normal lid position, as you can see, we have a rounded anterior margin while you have a sharp posterior margin that lies in close approximation to the ocular surface. It can either undergo inward turning or outward turning. The normal puncta, normally the puncta are directed medially and backwards, that is facing the globe, and usually you are not able to see them without everting the lids. Normal eyelashes, they are located outwards and upwards, the upper lashes, and outwards and downwards for the lower lashes. So as we discussed, this is the normal upper and lower tarsal heights, and the anterior lamella normal length is around 25 to 30 millimeter, while the minimum length that we should check for is 20 millimeter. So now moving to entropion. Entropion is the inward turning of the eyelid margin. The grading of this is a Kemp and Collins classification of entropion. It divides it into minimum, moderate, and severe. In minimum, there is conjunctivalization of the lid margin, and there is the lash and globe make contact only on up gaze. Coming to moderate, there is lash globe contact on primary gaze as well, along with thickening of the tarsal plate and some amount of lid retraction. Whereas severe is lid retraction causing incomplete closure of the eyelids and along with metaplastic lashes.
So this is only for the upper eyelid, this Kemp and Collins classification.
So now the clinical grading of entropion, there is grade 1 where only the posterior border is inturned. Grade 2 includes the inward turning of the intermarginal strip as well. That is the one that contains the grey line. And grade 3 is the entire thickness of the eyelid margin is interned. So this can be a grade 1 entropion, while this is a grade 3 entropion. So now coming to the classification, it is mainly congenital and acquired. In acquired, we have involutional, spastic, cicatricial, and marginal. So the anatomical changes that lead to congenital entropion is the hypertrophy of eyelid skin, and basically if the anterior lamella is longer than the posterior lamella, whatever the reason for it. Then coming to tarsal kink syndrome, it is a special type of congenital entropion where you also have a tarsal plate deformity. So it is only seen in the upper lid. It is unilateral and more common in males than females. Mechanism is either there is overaction of the orbicularis fibers, or there is a primary tarsal defect, or it can also be caused by mechanical pressure in utero. So the clinical features would be poor or absent eyelid crease, corneal scar, and microphthalmos. The management is mainly surgical, ranging from simple everting sutures to anterior lamellar reconstruction. So in general, the management of congenital entropion could be non-surgical, where we just give lubricant eye drops for symptomatic relief. It could be minimally invasive, where we are giving hyaluronic acid or any basically fillers injection into the posterior lamella in the plane of the lower lid retractors. It causes expansion of the posterior lamella. And we also have surgical management. So this is
what is that called? Correct. The other one. So it's epiblepharon, right? So what happens there is the lid margin is okay, but there is a presence of an extra fold of skin there because they are more chubbier. They have extra fat. Okay, so there's also, so it's not overriding on anything. It's just an extra fold of skin there. So lid margin will be intact. It's just the lashes which are turning in. So that is the most common cause of congenital entropion there. So if you look at that, laterally you look at the lid margin, that's good. If we would have taken a photo from the up, we would have been able to see whether the lid margin is intact or not. And what you're doing, the procedure there, yeah, that is, what is the surgery for epiblepharon? What is the spelling? HOTZ. Okay, so that's the HOTS procedure in which they've taken that, excising that extra fold of skin, and also they're placating the the retractors. HOTS is only excising the excess fold of skin. But here we've also plicated the retractors, and that is why you see there's an overcorrection. So normally in these cases, we like to achieve a little overcorrection. Okay.
Next, moving to involutional entropion. So there are three main factors. There is horizontal lid laxity, laxity of lower lid retractors, and also the overriding of preseptal over the pretarsal orbicularis oculi. So the lower lid retractors, their main function, they basically tug on the inferior tarsal plate, and this prevents the inward turning of the lower lid. So when there is laxity of these lower lid retractors, there can be entropion. This horizontal lid laxity basically pushes the eyelid away from the globe.
Go back to that. So basically factor number 1 and 2, they can either cause the eyelid to come out or come inside. So laxity of the lower lid or upper lid retractors as well as horizontal lid laxity can cause an entropion as well as an ectropion. Whereas your third factor, which is overriding of the preseptal over the pretarsal orbicularis, will cause only an entropion. Okay, so you have to distinguish, or you need to differentiate which factor is causing the entropion in this case, because that will help us plan the whatever surgical or non-surgical intervention.
Moving on to the next type, that is spastic. It occurs when the eyelids are in a state of constant spasm. It is intermittent and happens when there is contraction of the orbicularis oculi, which is the protractor, which overrides the retractors. It is most common after anterior segment surgery, especially after trauma repair. And the additional predisposing factors include horizontal laxity or retractor laxity. Next, moving on to the cicatricial type of entropion. Here there is shortening of the posterior lamella of the eyelid, which in turn causes an inward turning of the anterior lamella. It is most commonly seen in trachoma endemic areas, but it can actually be seen with any disease where you see scarring of conjunctiva. That could include Stevens-Johnson syndrome and ocular cicatricial pemphigoid, along with chemical burns or post-surgery or trauma. Then coming to the last type of entropion, it's the marginal entropion. It is basically a mild form of cicatricial entropion itself, and it is why we need to know it is because it is commonly misdiagnosed as trichiasis. But a careful examination would reveal a mild entropion as well in some cases. Moving on to ectropion, it is the outward turning of the eyelid margin, presents with similar clinical features of epiphora, exposure keratopathy, and pain. So we grade it with a mild outward as grade 1, 2, 3. 1 is just a punctal eversion. 2 is where the palpebral conjunctiva is exposed, and 3 is the exposure of the pharyngeal conjunctiva as well. Again, this is classified as congenital and acquired, where we have involutional, paralytic, cicatricial, and mechanical. Congenital ectropion. It is basically where the anterior lamella is shorter than the posterior lamella. It has various associations. As we can see, there's ichthyosis, Down syndrome, and also BPES, that is blepharophimosis, ptosis, epicanthus inversus syndrome. The management, again, you have non-surgical and surgical. Non-surgical, you can give lubricants, you can do taping and also hyaluronic acid filler. Whereas surgically, we can take inverting sutures. If there is associated horizontal lid laxity, we can do a lateral tarsal strip. And if there is anterior lamellar shortening, as we see in this case, we'll have to go in for a full thickness skin graft. Moving to involutional type, it is only seen in the lower lid. The cause is the age-related descent of the midface also causes displacement of the lid margin away from the globe. There are some prominent involutional changes like we have discussed before also, which is the disinsertion of lid retractors, laxity of the canthal tendons, or atrophy of the orbicularis muscles. Moving on to the paralytic ectropion. Mainly these are the causes where you have trauma, seventh nerve palsy, or post-surgical removal of acoustic neuroma that causes loss of the orbicularis stone, thereby causing a paralytic ectropion. So here we see a case of Bell's palsy where he has lag of thalamus. So this is just another case showing the same thing. Next, we move on to cicatricial type of ectropion. This is because of while cicatricial entropion was shortening of the posterior lamella, this is going to be shortening of the anterior lamella caused by trauma, burns, ichthyosis like we've seen in the congenital variety, and any previous lid surgery. So these are cases of cicatricial entropion. This one is caused by
Ectropion.
ectropion. This one is caused by chemical burns, while these two are caused by trauma.
Where were you? Asking whom? Whom are you posted with? फिर? ठीक है.
The final variant is the mechanical ectropion. Here you can see basically the weight of this any mass can cause movement of the lower lid away from the globe, as we can see here. So moving on to the clinical assessment. Clinical assessment can be divided and first we are going to go with the history taking followed by examination, where we examine the eyelid under inspection and palpation and finally move to the slit lamp examination. So we will be talking, we need to ask their chief complaint. For both entropion and ectropion, usually the history is quite similar. They complain of watering, irritation or any foreign body sensation. History of frequent eye infections is suggestive more of an entropion, and the duration of complaints gives us an idea as to whether it is congenital or acquired. The past history that we need to be looking for is ocular trauma, history of any facial burns or chemical injury, ocular surface pathology like Stevens-Johnson syndrome, ocular cicatricial pemphigoid, or needs to be inquired. Painful ocular pathology is more in favor of a spastic entropion as compared to a cicatricial entropion. Also the history of facial nerve palsy and any previous lid or ocular surface surgery. And also we need to ask for their previous pictures. So moving on to inspection, we mainly see the position of eyelids, the position of the puncta and the position of eyelashes. As discussed previously, this is the normal position of three of them, and any deviation from the same can give us a hint as to an underlying pathology. Some other pointers to look out for is a higher lower lid resting position in primary gaze, increased depth of the inferior fornix, if there is a subconjunctival white band in the inferior fornix, and if there is lack of downward movement of lower lid on down gaze. Then moving on to palpation, here we are going to examine the basically laxity of the lids. So first we go to the horizontal lid laxity. There are two tests. There is the eyelid distraction test and the snapback test. Eyelid distraction test is where you pinch the lower lid and pull it away from the globe, and we measure how many millimeters does it move outwards. Anything more than 6 millimeters is considered abnormal.
So you can just take a ruler also and measure in case you're in doubt. Okay. And you can measure. So anything more than 6 to 10 is generally called as in mild, and anything more than 10 is significant. So then you have to address that. Next.
So next is the snapback test. So in the snapback test, you're pulling the lower lid margin downwards and you're releasing it. So normally, as we can see in this patient, it snaps back immediately as soon as you leave it. So that is normal. Now when we look at this patient, it takes some time to assume normal position. So this could be graded as grade 1, and similarly if it takes 4 to 5 seconds, it's grade 2. Anything more than 5 seconds is grade 3, and if it absolutely does not resume normal position, it is deemed grade 4. Then you have the medial canthal tendon laxity, where you try to displace the medial, basically the lower puncta, and see how much it is displacing with that outward force. So if it moves anything more than 2 mm, or if the puncta moves beyond the limbus, it is considered to be, the patient is considered to have medial canthal tendon laxities. This patient is normal. Moving on to the lateral canthal tendon laxity, here you push the lateral canthus inwards, and if it moves more than 2 mm, then that means the patient has lateral canthal tendon laxity.
So when you look at lateral canthal laxity, you have to look at the position of the lateral canthus, B, the angle of the lateral canthus, and then when you displace the lateral canthus. So it's generally a very strong ligament per se, the canthal ligament which is there. So anything more than 2 millimeters of the lateral canthus is considered as positive. Whereas for the medial canthus, when you're displacing it, there's a grading for it 1, 2, 3 based on, like you correctly said, if it is beyond the limbus, then it is quite severe. Okay, so when you're displacing the lateral canthal tendon, that will also give you an idea of how much lateral tarsal strip surgery can you do without causing any trauma to the or displacement in the puncta position. Okay, when you displace, so that is also important when you're looking at laxity and assessment to plan your surgery as well. So LTS, that is lateral tarsal strip, is one of the most common surgeries that we do to tighten or take care of the horizontal laxity. So if you do it too much and the puncta is not in a normal position, the patient will still have epiphora, right? So that is another thing that you must look at while assessing.
Then we have how we check the laxity of lower lid retractors. We palpate beneath the inferior tarsus, and we can it can reveal a disinserted edge of the capsulopalpebral fascia. We also assess the fornicial depth, which is increased in case of lower lid retractor disinsertion, and it is decreased in cicatricial conditions. Finally, we have the dynamic assessment, where we ask the patient to close his lids tightly, and we look for any overriding of the orbicularis. As we can see, this patient has it here.
You can clearly see, it's a very good video. You just look at the left eye, what is happening to the left eye and what is happening to the right eye. Can you guys see the difference just below the lid? You see there is an orbicularis overaction there. You can see that the right lower lid is much more fuller as compared to that of the left. So that is an indication that there is an orbicularis overriding in that area per se. Okay, below that is a fat prolapse, but you look just above that.
Then we also assess for any facial nerve weakness. We look for lag of thalamus, facial asymmetry, or any deviation of the angle of mouth. Finally, coming to the slit lamp examination, we look at the cornea for exposure keratopathy, any superior pannus or limbal stem cell deficiency. The conjunctiva is assessed for congestion, symbeferon, or a thickened tarsal plate, and the eyelid margin is assessed to differentiate between trichiasis and entropion. Also, a keratinized lid margin could be suggestive of a cicatricial condition. Moving on to the management of entropion. Based on our grading, we can plan our management. So in mild asymptomatic cases, we usually do not need any management. Coming to mild symptomatic cases, we go for non-surgical management, where we give lubricating eye drops for symptomatic relief. We can put a bandage contact lens, and we can also, with the help of taping, cause temporary eyelid eversion.
This is all when there is an underlying cause. You don't give BCL in all cases unless there's something happening with the cornea, right? So that you can do taping in mild cases, that is there. And lubricants you just give to ensure that the entropion is not going to cause any further corneal or ocular surface problems.
Then moving to moderate entropion, we can use both non-surgical and surgical techniques here. We can do quicker sutures, or we can inject botulinum toxin. Surgically, the most common procedure, like we discussed, is the lateral tarsal strip. We can also do an inverted T procedure, Jones procedure, and a Weiss procedure. Severe entropion is going to require replacement of the posterior lamella. We can either you can take autologous tissue for it, allogenic tissue for it, or synthetic. Synthetic is, we don't use it. Autologous tissue, we can use conjunctiva or the tarsus of the other eye, and allogenic, we have grafts like we can use a mucous membrane graft or an amniotic membrane. So coming to quick-cut sutures, they are everting sutures, which are taken full thickness through the conjunctival fornix, and this strengthens the lower lid retractors. Then coming to the quick-cut procedure, it's basically quick-cut sutures along with a lateral tarsal strip and along with an inverted T procedure. Inverted T procedure is where you take a triangular wedge of the tarsal plate, approaching it through the conjunctival side, and that is done to reduce the horizontal lid. Botox injections can be given subcutaneously around the area of the orbicularis oculi, and they cause relaxation of the muscle, which can basically cause eversion of the Next, coming to the lateral tarsal strip.
Okay, we'll play the video for this, but we've already discussed about the laxity part of it. So, yeah, assessment of the horizontal laxity.
Next, moving to the Jones procedure, it is the application of the lower lid retractors, as we have discussed earlier. So, here you make an incision on the lower lid and you pass these double-edged sutures. The difference between the Jones procedure and the Weiss procedure is that in the Weiss procedure, you're taking full thickness everting sutures.
So, in Jones procedure, incise the skin orbicularis septum. Okay, behind the septum, you identify the retractors which are disinserted from the tarsal plate. You identify them and you plicate them back, like how you do in LPS in the upper eyelid. Whereas in the Weiss procedure, I mean, that was a Jones. So in Weiss procedure, what you do, full thickness incision you take. And then you assume that you're taking the retractors. It's not always that you identify it, okay? Many a times you might not be able to assess and identify it. But again, this is a similar principle of that of Pickard sutures. What is that? You're taking a full thickness incision and inducing a scar so that your eyelid position comes out. That's all.
So coming to cicatricial entropion particularly, there are some ways of managing it. If it's a mild to moderate cicatricial entropion with or without trichiasis, we can go for a resection of the anterior lamella and also go for a mucous membrane graft. Whereas a moderate.
So this is something that you guys might be seeing in surface posting very regularly. Okay, when you have a mild to moderate, where it is not very significant entropion, you're still seeing the lid margin, there is lid margin keratinization with some few trichiatic lashes. You can resect that area where there is keratinization and replace it with the mucous membrane graft. So when you do that, you take care of the trichiatic lashes as well as the scarring which is there at the lid margin. Now, when you have moderate to severe with a lot of scarring at the level of the tarsus but not at the level of the margin per se, that is when you do some kind of a graft or a spacer to replace that scarred area which is there. Okay, that's the principle.
So this posterior lamellar replacement, like we have discussed before, we can use a mucous membrane graft or an amniotic membrane graft.
Okay, we don't really use amniotic membrane grafts. If you're using it as a spacer, it has to be something which will give little support as well as once you release the scar, it has to give some kind of a support and space. AMTs will not do that in the lid much. But AMT can be used if you're releasing a symblepharon, but not at the level of the lid. Okay. So most commonly what we use is mucous membrane graft. But there are others also that can be used, like you can use an auricular cartilage or a palatal graft. However, you have to choose well because all those auricular cartilages and palatal grafts are very hard and can cause further abrasions on the cornea. So you have to choose wise. You can take even the tarsal plate from the upper lid as a spacer if you really need to use it.
So moving to the management of ectropion, here again we manage it based on the grade. A mild ectropion can be corrected by conjunctival spindle sutures or by simple inverting suture. In case of moderate ectropion, we can do a lateral tarsal strip, medial canthal tendon plication if there is medial canthal tendon laxity, as well as lower lid retractor plication if there is lower lid retractor laxity. Whereas when we move to severe ectropion, we again replace the anterior lamella by a full thickness skin graft. So lateral, this is ectropion that was corrected with the lateral tarsal strip procedure. Then some management of ectropion based on their types. So there are some other procedures that can be done for involutional ectropion. We can do horizontal lid shortening, where we do a full thickness wedge excision. This is done where there is horizontal lid laxity. Then we have something called the Kunt-Szymanowski procedure. It is done if there is excess, like a redundant lower lid skin along with horizontal lid laxity. Here you do a full thickness resection along of the redundant skin as well. Okay. Then we can also do medial canthal plication if there is medial canthal tendon laxity. Then moving on to the paralytic ectropion management, there are again temporary and permanent measures. Temporary will be mainly to protect the cornea. So we give lubricating eye drops, we can give Botox injection, or we can even do a temporary tarsorrhaphy. Whereas permanent solutions, again, these are the surgeries that we have discussed before. If it's an upper lid if it's an upper lid ectropion, we can even put a gold weight implant to assist closure. Then here, as we can see that this patient had come and a medial tarsorrhaphy was done. However, it was not sufficient enough, as there still is some lag of thalamus. So MCT plication was done in its place.
If you see, there is a left eye also medial ectropion which is there. You see lower lid is much lower. There's a lower lid inferior scleral, lower lid retraction is there. It's aesthetically not very good. That's why I decided to go ahead and we decided to do a medial canthal plication on both the sides. And then you can see that the result is better there.
Moving to cicatricial, here in mild cases we can just do simple lid tightening procedures, whereas in severe cases we will need to cause lengthening of the anterior lamella, like we've already discussed. There is also non-surgical management of the same by giving 5-fluorouracil injection. Thank you.